Dr. Madan.
Bhaswati, thank you so much for holding this group together, and a diverse collection of minds and ideas and thoughts running from the very ancient to the very modern, to aspects relating to food and standardization and the quagmire of standardization and much, much more. I'm going to start off with a few broad comments in that when we talk about evidence and we talk about scientific evidence, there is a method to it. And I think that has come through very clearly. Bhaswati, before I go on, is my audio loud enough for everybody?
Yes, it's fine.
Yes, thank you. So we've heard different perspectives, and we approach this problem based on our backgrounds and how we've been trained to think, etc., etc. And is there a axiomatic approach to what evidence is? And this is a question that has given rise to the 9 systems of philosophy that we have in India, the 9 dominant types of systems of philosophy, so-called the darshanas. And one in particular, I put it on the chat list, is Sankhya, that Bhaswati has been kind enough to alert. Sankhya is a ruthless and an axiomatic approach that gives rise to the large body of thinking that goes on to making what is much of the applied Indian sciences that we have today. Now, I've given the reference to Sankhya and the 68 Sutras. You can find them at that link. I'll add the link to the PDF with the 68 Sutras. Now, what this tells you is that there is an axiomatic way to arrive at evidence that we want to. And we are very fortunate, and I'm so happy that we have knowledgeable people here who at least have heard about it. They're not shocked about things like the darshanas and the different ways of perceiving reality. So this is what we have. We have a challenge of approaching reality. And the comment made by Dr. Rao, Dr. Rammohan Rao was very important, that we need to press towards arriving at this circularity in bench to bedside and bedside to bench. And I think if we can achieve that as one major outcome of the ongoing discussions, that would be really wonderful. And we look to you, Dr. Rao, to give us guidance to take us on, because it looks like what you're proposing there in California is getting some traction, major traction, particularly in terms of the COVID-19 ongoings. What Bhaswati ji has offered us today about the evidence that's being gathered for the disasters that come out of using approaches that are anti-health, which is the approach of intubation that's been proposed. And I've put a reference there, which is from the Times here in the UK, about why this motivation to get towards such an approach. And there may be other ways to activate the GI tract. There may be a way to activate the GI tract via the olfactory nervous system to arrive at better respiratory health, to enable better survival in this case. And I'm going to share just one slide to give us this grand picture of where we are in terms of statistics and important evidence. This is from the WHO website on COVID-related deaths. Now, I want to put this up here for a minute, just to give you an idea of where we are in terms of deaths, mortality, in terms of other conditions. It's a very revealing slide. If you look at the 6 regions of the WHO, the secretariat that's harnessing health statistics, and if we see where COVID sits in this profile of causes of death, you come into Africa, you will find it is insignificant. So that's for 1.5 billion people. COVID is almost unscorable, the total number of deaths in that region for Africa. I want to go region by region so that you get an idea of what the problems are and where these biases come in. And we've touched on all that, the biases about policy making, the biases about pharmaceutical interventions. Look up here. In the period between 1st of Jan to 1st of December, 11 months of this year, COVID, in comparison to Africa, has scaled up to cause number 2 for deaths. Almost 11% of deaths in the Americas region is because of COVID. Now, if you did a little more dissection of this data, we'll be able to take it down to the member countries. And if you did a little more work, you will be able to take it down to cities in the member countries, and you will see the huge biases. And as we go down this list, Eastern Mediterranean, Europe, Southeast Asia, and Western Pacific, comparable to Africa. Now, for me, what is striking here is the Americas region and Europe, where it's the 4th largest cause of death this year, are the 2 most well-serviced health industries in the world. Now, this is a bit shocking that we have statistics of this nature, that the most well-resourced locations in the world in terms of health and health budgets show us the worst statistics. So there is something there for why we need to revisit and gather data about these things. So Bhaswati, you want to say something, please?
Yeah. I hope that you'll talk about the confounders and the severe bias of people just taking random numbers and putting them into a graph that they feel is true because it's got a WHO insignia on it. I just totally look and I can tear it apart in 1 minute.
Yeah,
and I'm
do
sure
elaborate, because it takes us to the heart of evidence, you see. So please add.
It's not evidence.
We know about
I want the other 3 to tell me what they see on the graph first. To my dear panelists, whoever wants to go first, Dr. Rao or Dr. Arti, do you want to go first? Madan, you can show that again, maybe,
I'll put the thing again. Bhaswati is able to mine this data and might be able to do it very swiftly. But the question is, this is what the world is seeing. So it's not me presenting the data. This is what the world is seeing. So here it is.
No, it's not.
The point here is when it comes to COVID and international dialogue, this is what the world is seeing. Now, we may have our interpretations, and this is what the whole debate is about, you know.
Yes.
Is this scientifically valid? And what are the concerns about this data? And how can we work into this with clarity? This is data, whether we like it or not, this is the data that's out there. And I'll leave it with you to kind of see if we can review this in terms of scientific evidence.
Dr. Rao, do you want to start?
Yeah, so this has been very confusing, right? I mean, time and again, we've been asking this question. Why is it that, the so-called the rich countries, as America or Europe, have such a huge number of cases, whereas poor countries did quite well? What is it? So now, the data is there. I mean, Dr. Madan has just shown it. Now, the question is, has this been replicated? Yes, okay. And it's been presented by WHO. So there's some amount of credence to that data. The question is, now we can go back and dissect and see, okay, having that data, let's go by that face value. We have those graphs, we have those numbers. The question is now, do you want to dissect that and say what exactly has happened? Why is it that rich countries have got more cases compared to countries that have absolutely, I mean, when it comes to Africa or when it comes to Asia, where we have very, very poor hygienic practices, okay? And we are supposedly they are not the rich world countries, and yet they've done so well. Well, if you go back and look at some of the things that these countries are doing, maybe, I mean, now you can dissect it. There are reasons. I mean, I don't have to tell that. You clinicians, you know that. Why is it that those people are doing much better? Is it because in terms of their immune response? Is it because they've already been exposed to, is it because they've already been exposed to not just corona, but other viruses, and so their body's already prepared for it? Is it because of the environment that they're living in? Why is it that in the US these days, the clinicians are advocating people to raise their kids in the farmhouses? And they are saying that go back to the rural areas and make sure that your children actually dive into the pigsties or dive into the cow herds, and then make sure that they put their hands into the cow poop and all. Why is it they're saying all that? Because they realize that, you know, it may be a rich country, there may be a lot of technological advances, but in terms of, you know, we have become so refined, our guts have become so refined that we are not able to tolerate these insults that come to us from the environment, which may be much more better in terms of those countries that have poor hygienic practices. That, I mean, reasons can be given. There is no doubt that if this data holds good, you can give a number of reasons, and all of them stand good, at least the ones that I've told about right now in terms of inflammation.
Okay, hang on one second, Dr. Rao, we'll come back to you. Dr. Arti, what do you think of these data and the denominators?
For me, there's a lot of questions on this data in terms of its validity. The most obvious, if we're saying, my goodness, it's only 1% in Southeast Asia, what the hell is India doing taking up a Pfizer vaccine right now, if it's so low and insignificant? That's my first question. My second question, when we come to, let's say, Europe, and let's come to UK, where the largest subgroup of people who are presenting with cases are a lot of minority groups like Asians. So then how does that correlate with that one? Why is it that Asians in Europe are getting it? And how do I identify in that 5% within Europe, which can be specific to UK, which can be specific to those minority groups? Where does that sit in? And if that's the case, what is it that the vaccine that is going to India should do to the people who are in Europe who are of Indian origin? I don't know. This is really, and then I look at the Americas. Okay, so it's a second highest. So now what I want to ask in the Americas, how many people are compliant in terms of self-isolation, protection? What are they doing in terms of management of the condition? And overall, can we really be sure that this is COVID-19 by itself, or is it a comorbidity? Because then that also changes the data a little bit too. So there's for me, there's a lot of, no, it doesn't make sense to me, unfortunately. I'm sorry. It looks beautiful. It just as a descriptive thing, but no. And I could go on a little bit more. I could dissect it even more, but I'll pass it on to somebody else too.
Go ahead, Madan, and then I'm going to say what
I want to re-emphasize the point I made, which is we talk about evidence, and we've talked about the biases in evidence, and we've talked about the reason for the biases in evidence. And if you look through the chat box, you'll see a lot of information from researchers' minds around the world who've thought about this problem. And we also know that there are reasons why there are policy biases. So we know all that. And we also know that here is data that is flashed to the world. The first place anybody in government would go to look at COVID statistics is the WHO database. The link is there on the bottom. There are two links at the bottom of that slide. So this is where they would go to look at this information. Now, the big question is, what is it that small groups can offer to question this data? And I think this is the key thing. And we are at a very interesting turning point in discussions and dialogues around the world, like what's happening right now, which is we connect around the world with such ease. Are we doing enough to take data of this kind and ask questions? I don't think we are. And the reason why we are not is because perhaps we're not thinking through the problem correctly. Bhaswati, all yours.
Yeah.
Now, I wait to hear your dissection of this.
So I wanted to say, it looks like Dr. That's right.
Hello.
So Dr. Sastri is still on mute. So I think he's not going to say anything right now, but I would love to hear from him as well. Dr. Sastri, I'll go ahead and speak and then you can come back on unless you want to speak now. Professor?
If I may just add one point while Dr. Sastri comes on, look at Africa here. The reason for COVID, such minimal amounts of COVID-19 death is just the demographics of Africa. When we look at COVID deaths today, we know it's age dependent. There is a linearity in age to mortality. Africa,
that's right.
I don't know, 50% of Africa is less than, I don't know, 10 years of age. There are certain countries where half the population is less than 5.
That's right.
So Dr. Madan, there was...
It makes sense.
Absolutely.
And the same thing here, yes, there are biases in how the COVID-19 statistics is collected in America. We know all this, but it's a trend. And there is a contrast here between Africa and Americas. And
so with regard to Africa, there have been some studies where they have shown demographic is definitely one of the reasons. They say a young demographic profile.
Yeah.
In Africa, there's also, they say one of the other which is now being implemented here is the greater use of outdoor spaces, probably because of,
yes.
maybe because of their structure. And of course, which clinicians all over across agree that, Africans in general have very high levels of potentially protective antibodies from that they gain from other infections. So Africa is, I've seen a lot of reports both in Lancet, in medical journals and in other scientific journals about Africa as to why it is lower. As I said, you can, the denominator has to be very important in these graphs. We have a lot of other questions that we have not approached, but given these facts that you're now putting up on the slide here, there are certain things that we can gather from these. And one of the things that Dr. Fauci here is trying to explain to the people is the greater use of outdoor spaces. That's what he's telling. He's telling us, make use of the outdoor spaces. Probably this has come from Africa as an example.
Thank you. Thank you, Ram. Bhaswati,
okay.
If I may just add one more thing about the neem oil experiments and also the gut cleaning studies. Could you tell us a little more about these two?
I can, but I want Dr. Sastri talk about this because
okay.
He and his wife, my former friend Savita Sastri ma'am, was a biostatistician, and he is an expert biostatistician. Dr. Sastri, when you see these data just as they are, I'm not going to call them facts because I think that they are wrong data. Can you please talk a little bit about this?
I just talked for a couple of minutes. 2 days ago, there was a report which said that a Spanish town of 1,600 people were tested completely, 100% testing. And they found 70% of the people had COVID at that point of time. All asymptomatic.
This is
Now, my worry is very different here at this point of time. The other 30 probably did have COVID, came out of it, and are asymptomatic, and they are not probably showing themselves as positive. I had COVID, and I was in the hospital for a week. I tested afterwards. I was tested negative, which means if you had tested me at that point I voluntarily went. If you had tested me 15 days later, if I had survived, tested me 15 days later, perhaps I would not have shown COVID. So this data is very, I only use the word very confusing. In that Spanish town,
This is not cases.
70% had COVID. That's all I can say.
Dr. Sastri, I just want to qualify that this is to do with deaths.
Deaths.
And not cases.
And not cases. Bhaswati, would
Okay.
you like to?
Yeah, so first thing, look at the way they've delineated the countries. If you go with the hypothesis that people with very full bellies, full of toxic dead food, then yes, you would put America and Canada in one area, but you wouldn't put South America with that. Second, if you go by hemispheres and you talk about temperatures, then when we were in the peak of COVID in our winter months, which was January, February, March, April, May in the Northern Hemisphere, the people in Brazil, Chile, Argentina, Paraguay, Uruguay were having not really a lot of cases. So you have to go with hemispheric changes and not go with one whole year. That's one. If you look at what America has, America and Canada both have incentives for showing that there's more COVID because resource allocation goes by that. In Africa, resource allocation doesn't go by that. There's no reason to put India and China with the other countries because they all have different ways. Australia has had a very different way of dealing with COVID than New Zealand. Vietnam has had almost no cases. Here has Japan. They've had cases, but they've really, taken care of them very quickly and efficiently. South Korea, you cannot block people that are in one geographical zone as though the zones mean there's a population there. They are not contiguous. So that's a second point. Third is look at how India is clubbed with this whole group. India is a very, very different population because we have all of those people from Mecca who actually came in and started the first cases in Delhi and Cochin and Mangalore. That's where a lot of the cases came in from. If you follow what happened in February and March, where did the cases come in from? There were people, I'm not supposed to talk about this because it's confidential information, but the secretaries who are in very high levels of government know that there was a particular subpopulation that was going around licking handles and doorknobs and things to purposely spread COVID. And they were using themselves as vectors. We know this as a fact. The secret intelligence knows this as a fact. And let's just say that there's a lot of people that know this, okay, because they've witnessed it. So India should not be put with all these other countries uniformly. Then I can't remember the whole map, but all of Africa is not represented. There was a whole section of Sudan, Ethiopia, and I think it
is. I just want to say, keep in mind, these groups of countries based on the regions. It's got nothing to do with, it has little to do with the countries as such, you see. This is WHO statistics based on the countries in the regions. So
assuming contiguousness, and there's not contiguousness, number one.
And it's put there for resource allocation in terms of planning. So there is a reason why they've done it, and there are trends. So
if the people are different. If I were to treat everyone in Calcutta the same, there's some very, very wealthy people. If I were to give them the equal amount of money that I give to someone else who's very poor, you can't give resource allocation to two different populations that are located for your convenience in the same region.
I think it argues well for what you said about the Nagar concept. See, I think it's wonderful that it adds value to what you said about the smaller concept of towns.
Another is who grows their own food, who eats dead food, who has fresh food. People that eat their own fresh food have been doing a lot better with COVID than the ones that are eating dead food. There is one guy who's studying this quietly. He's tried to publish it, but the people that publish are these Vaidya scientists who think that they know a lot about science, and they keep criticizing his papers because he refuses to translate Ayurveda into their convenient, Vaidya scientist kind of parameters. And I just spent 4 hours with him today, and he was talking about his hypothesis that it's always upchaya. And I don't know if Ram and Arti, who are with me in Ayurveda, can say, about this, but if the amashaya is full of ama, it's obviously going to support the progression of COVID, whereas when they do Langhana and they do Mridu Virechana, they have found that people don't get sick. There's another group of Vaidyas who did try to do a study, but they don't know how to do clinical research. They tried to look in March, April, and May at the people that had had Panchakarma in the preceding 6 months. And they found overall that no one got COVID if they had had Panchakarma in the past 6 months. What does it mean? It means that their guts were fairly clean.
Yes,
So
absolutely.
that makes sense to each of us that practices Ayurveda. But if you go to that map and resource allocation, there are a lot of people in Netherlands that I know that do Ayurveda, and in Germany and in France. Were they just in that group? They have a very, very different prognosis because of their individual choices. Ram talked about physical exercise. Dr. Sastri makes food for people. He looks at how food is made. Arti does Siddha. She knows about meditation, yoga, and the energy level of people. These things are not even being considered because WHO allocates resources equally. If you give me 10,000 rupees right now, I'll be like, okay, thanks. If you give it to my maid that works in this apartment, 10,000 bucks is more than she gets paid in a month. She'll be so happy with that. Resource allocation cannot be equal for people just because they're in a geographical location. I just want to say one more thing about the data. When you take a year of data like that, you need to compare it not by the total number of deaths that happened, because reasons and all different population demographics, as you said, right, based on the population pyramids, but you need to compare it with a 3D graph of how the deaths looked 1 year previously and compare them to themselves if you're going to use population zones the way you are. So you need to have that same graph for the year previous in 2019 and then show it for 2020 if you have to use those resource allocation boundaries. They had so many, I mean, you just can't give.
Thank you, Bhaswati. I think we get what you're trying to convey. I'm hoping somebody in WHO is listening to these comments being raised. And this is the very reason for putting this up today. And I've also put later on, what I'd shared later was how you might want to dissect country-specific data, you know, and I'm putting this up again for Vietnam. Very striking data, you know, they
stratify the data.
Say they have only, they have a population about 1.5 times that of UK, 1.7 times population of England. Total cases to date is just under 1,400.
Yes.
And total deaths is 35. So there is a way, but the reason why I put that up is because it is topical. It comes into the COVID area. The COVID area and the evidence and the pathophysiology of COVID is still far from even, I don't think we've even understood the early bits about COVID-19. There's a wonderful paper from Taiwan that shows how patients who turn up in hospital for acute care have a very high gut flora, microflora for pro-inflammatory bacteria and a very low incidence of anti-inflammatory bacteria. So all of it makes sense. The point I'm trying to get to is why aren't we in a position when we've never had such democratic debates across the globe as we are having today? Where are we losing the opportunity to influence discussions? And this is the very reason why I put the WHO statistics there. It's well and good. We talk about Ayurveda, we talk about Mridu Virechana. How quickly can we take whatever we have shape it into an argument that can be used for hitting the heads of people who are unable to kind of bring about policy change. And this is the whole reason. I think we are getting all the arguments. There might be some thoughts coming from the minds here among our participants. I don't know if somebody else wants to join in. Bhaswati, maybe you want to bring in Kamalji, Kamal Banik. Kamalji, namaskar.
Dr. Banik to open his video. I asked him privately to please.
Okay, Kamalji has put a lot of things here. While we wait for Kamalji, I want to bring our heads back to that one important question. What is needed now to convert all of what we've talked about today in terms of applying oil in the nose, getting some evidence for that? when is that going to turn into a global practice like what Pfizer are doing now? In the chat box, I put a comment there about the company that, that has taken over the rights from Pfizer to produce vaccines in India. And the complex politics there that's going on.
Well,
the company, the Vaccine Institute in Pune, has just filed a case against the person who came up saying, I have side effects on this stuff. How come we are not? So I just want to go back into that space a little more. Two questions. If we have any data like what Ram is saying, that 4,000 patients, you have some data, how quickly can we turn this into at least a half coherent statement that can be taken across the world through the WHO or otherwise to put the brakes on this nonsense that's going on? Number one, can we put those statements together? I'm particularly interested in bringing this statement together because on Friday the 18th, the Ayush Valley is putting together an event on management of post-COVID or long COVID using Ayush systems. And I'm hoping that we will, all of us here and all of us who are listening to us on social media, will get a chance to come back again in less than 2 weeks' time to look at this thing so that we have something that is concrete and we can say, out of our discussions, we looked at the WHO data, we feel this is biased, this is not the way to present data. Number one, take that chart down from your website for all of these reasons. Unless you can put valid data, scientific evidence in a better way, that chart must not be there. It must be taken down. Number two, here are our arguments for why we need other approaches. And here is how the neurophysiology works. Here is how the neuroanatomy works. This is how the anatomy of physiology works. And where is the evidence for this? What are you doing? What are your member states doing for this? And here is our recommendation. And finally, whatever this thing is that's going around, we now know there are people who've been into hospital, who've gone through this phase of all the symptoms that are known for COVID. They come out of it, they have other symptoms. And here is what we have to offer. What I find very disappointing is that we never seem to have the ability to get that coherence. We still seem to have very independent workers who are not able to come together as a team, are not able to come together to form a coherent statement, and are not organized enough to take it to whatever levels that it needs to be taken to so that it becomes policy across the world. And I think this is one of the big functions of the Ayush Valley Foundation, to start to harness this kind of coherence that is needed. And I don't see it happening. I will carry out a conversation in private with many on this panel today to see how we can enable that.
So Dr. Madan, just to go back on what you said, and then combined with the Sankhya philosophy, if everybody on this panel or in the world get together without their ahankaras coming in the forefront, then it is possible. The problem is that big ahankara that's coming in the forefront, which is being pulled by every other incentive, whether it's pharmacological, whether it's wealth-based, whether it's richness-based, whatever it is, that as long as the ahankara is there in front of you, it's not going to work. And then the problem is even those people who want to make a change, who want their voices to be heard, the thing is, it's all in the minority, but I still see it. I mean, given my background, I still see that there is a progress, but as you rightly pointed out, it's going to be slow. And right now we need, as you said, we need a rapid task force to come forward and do it.
Thank you. Thank you, Ram, for mentioning this. You are part of the task force now. Thank you for joining us on this event. And all of you here with us are part of this task force. And over the next 10 days, we will have a chance to distill all these discussions. It's wonderful that we are recording all these discussions. and perhaps the emotion and passion that's coming out from all of you will be captured, and we will be able to revisit that and re-energize so that we can restructure. We can think through what is it that we want to take to the WHO office in Geneva. And I think we have enough brain power here amongst us to be able to do that. So let us not underestimate the strengths we have here and what we've gathered either as standard evidence, what is presented in the press, and what is evidence available locally in the community. Even if it is one case, it is evidence. It's just that we need to dig deep to find the energy to pull it out and to phrase it correctly so that it lands on the table of people that are involved in this, in policy making. And if we can't do it, I don't expect anybody else in the community to be able to do that. If we as a group cannot make this happen, then I feel there's nobody else in the community who have the skills and who have the ability to pull this off. Arti, please.
Sorry to interrupt you. Dr. Madan, since you're working with Ayush, my original comment that I made about how to bring all these different sciences, what I meant was the different hats right now, which we're calling Ayush. How amenable are they to coming up with active solutions? Because they're, as far as I'm concerned, sitting in the country, holding those regulatory stroke educational bodies in a certain place, whether they're...
Archie, do you mean the Ministry of Ayush or
yes, Ministry of Ayush.
Now, on the 4th of, so this was, today we are, where are we? We are on the 4th, this is on the 4th of December, we had a wonderful meeting there between the Minister of Ayush, Shripad Naikji, who's also Minister of State for Defense. Not many people here might know that he's also Minister of State for Defense, with our Minister of Commerce, Mr. Goel, Piyush Goel. And yes, there is an economic aspect to these decision-making in cabinet. And I think it is not fixed in stone. If we put together a drafted document, we can make an impact at decision-making. And this is the point I'm making, we have to be proactive in that. We have to, yes, we might have a way to dissect that data and argue for weaknesses. And we must be in that position to offer them guidance. They don't know how to dissect this data. They wouldn't know what are the errors. I don't know, there's a call now for retraction of that first reverse transcriptase PCR test that was put together by the German scientists. And there's a big call, if you look at the rebuttal for this whole thing, it'll tell you what are the problems. And I think they will have to retract that paper. And once that paper is retracted, it will explain why we have so many false negatives coming out in here. Yes. Yeah. Because, the way the primers were designed and the way things were done, the reason why I put up the Vietnamese data there is because they have developed a completely different set of tests with good internal controls, completely different primer sites, and very rigorous testing. And that entire work was done by the military school in Vietnam before it was given out to the university for marketing. So there are big conflicts of interest here. And there has never, ever been an opportunity in global healthcare to pull the whole sham down. And if we are not quick enough to do this, then we are to be blamed for this. So this is what I want to say. And it's a very timely thing that we are doing this event on scientific evidence. And we are thankful to the Ayush Valley Foundation for enabling these 3 wonderful HardTalk programs that have come through. And thanks to Bhaswati for holding us all together to make this happen. And, the onus is on us to gather all whatever data that is there in the community, whether it is applying till oil in the nose or neem seed oil, because each of those oils have different pharmacological properties. It's for us to show this is what it costs. This treatment costs so much. Here is Virechana. And the reason for Virechana is because there is crosstalk between GI tract microflora and the immune system. There's crosstalk between the vagal nerve activity and inflammation in the lung. There is evidence for all of this. If we cannot pull that data together and argue for it, then we could sit here and talk forever, and we wouldn't have arrived anywhere. So I'm trying to inject this energy into our hard talk today in a rather forceful way by saying your jobs haven't finished. You have entered the snake pit and you're going to kill the snakes here. So welcome to the snake pit. And we know what the facts are. We know where the problems are. We know who the troublemakers are. I want to point my fingers directly at the Vaccine Institute in Pune.
Serum Institute.
Yes, Serum Institute in Pune. Now, these guys have the audacity to go to court.
Right.
Now, today evening,
after Modi saw them. So the question, what was the relationship between them going to court and Modi visiting them the day before? Because he specifically went, SII was one of the 3 places that Modi visited, and it was all televised across India.
It had to be done that way. Now, what I want to put another bit into this equation here. We've been discussing in several other places, including our second hard talk on homeopathy. Why does homeopathy work? We had very inspired speakers there who showed that homeopathy works. In homeopathy, there are 2 treatments that are being used, arsenicum album and something else. And this is providing a prophylactic effect. Mm-hmm. Yes, there is
not just
guidance here from bedside to bench, what is being done here.
Yes.
Ram, the comment you made about bedside to bench, there is evidence. There are communities being protected by this.
Yes.
So there is an ethical dilemma here in terms of, so later today, somewhere starting in an hour's time, the chair of the ethics committee for the Kerala University of Health Sciences will be debating this thing. And he says, India should provide leadership in ethics committees, where hereafter, every ethics committee in the country should have members representing all the modalities.
Yes.
If it is a medical ethics committee, then we should provide leadership saying our medical ethics committee will have representation from all the Ayush modalities.
Right.
And we will become the world leaders in that whole aspect of thinking about ethical aspects in clinical trial design, ethical aspects. And these are the high points that we want to reach so that India and our ancient systems of sciences and thinking can be seen around the world as offering global leadership when it comes to health and well-being and when it comes to aspects. So these are the high points that we want to reach from these kind of debates and discussions. So Bhaswati, back with you, sorry. I take your point very much about this was one of the places that the Prime Minister visited. He had to do it, he didn't have a choice, because this is a big intervention that comes from, and as with all these things, they're double-edged swords. You need to know how to move the sword. You got to know which way to move it to cut which way. And I think it's one of those things in politics, I guess. And we must be mature enough to know how to get the sword to move in the direction we want it to move. Otherwise, it'll get you. So there we are. Thank you.
Well, I don't really care that Modi went there. I'm sure that everything was very, very much orchestrated because it was such an amazing PR event. They watched him, going from the helipad to the car to the institute, and all the people were positioned there with their masks on, and everything was a photo opportunity. I don't know how much science was actually discussed there, but the people that had press conferences standing next to Modi, it was a life-affirming moment for them. And that's all that I noticed out of those 3 visits that Modi made. And I think he did it to quell or to encourage or to make a political statement that India is also in the process of creating vaccines. We don't need to wait for Pfizer and AstraZeneca and the fiascos that have happened with scientific data between those, different companies. That is not my concern. My concern is what actually works for patients, as Dr. Arti was saying. Where do we take what we've been doing and apply it to where it really matters? The WHO people are fending for their own space. I know lots of people at WHO. I went to Harvard. Half people from the School of Public Health have worked for WHO. I know lots and lots of the politics that goes on. They are working to preserve their own positions and their maids and their corner apartments and their car and driver. That's their priority. The health of the people is not the priority.
Yeah.
What I see on the ground in India for the actual Vaidyas who are working with patients quietly and illegally and trying to help patients. One of them talked with me today, is a different conversation. And he was saying that in March or April, he was called to a meeting at his state commission because, as many of you know, there was a national meeting about COVID. And then in each of the states of India, because they have to decide on their own laws, there were state meetings. So he spoke directly to the commissioner, talked with her about some of the methods that he'd been using, some of his hypotheses in Ayurveda and what he'd been seeing clinically. This is a guy that has worked 6 a.m. to 11 p.m. He's an Ayurvedic Vaidya working in an allopathic hospital, and he sees lots and lots of patients. And because they had a huge rate of mortality in March, April, May, well, it wasn't so much March, it was April, May, June. He was finally allowed to intervene, and his numbers were very different than their numbers because they had very high mortality. So he talked with the commissioner. She said, "Oh, I would love to have you write a paper. Why don't you work on this committee?" Okay. Now, when I hear committee before, when I was in my 20s, 30s, and 40s, I felt so prestigious to be included among them. But since I have worked at the various universities that I have, being on a committee is like saying, let's put you into liquid nitrogen and freeze you. Because the committees, okay, so in his case, what happened? He went to the committee and he said, "Madam has asked me to give my inputs on what I think works for COVID." So we're talking exactly what you said, Madan, about the data on the use, the procedures, the mechanism of action, and the cost analysis. He went through those 4 points and he talked with them about what he used and how it was definitely cheaper, how it was working in this way. Here are his data. This is the mechanism of action according to Ayurveda, not according to modern medicine. Although, he had some kind of putative mechanisms of action. And here's the exact procedure by what we do and the algorithmic way in which we decide how we're going to do it. And he had already tried to start submitting the data to one of our very famous, Scopus indexed, peer-reviewed medical journals in India. So those people on the committee said, "Are you kidding me?" And I'm going to just say this on record. He said, "The people in the central Ayush system will be so angry if you're the one that comes up with this. I am not going to write that memo with you. I do not want to offend those people because they need to feel like they're in charge. If we come up with something that works, that looks superior to what they've put together, it's going to be very bad for us. And the repercussions for us for funding for the rest of our colleges and various approvals is not going to happen. And you have to learn how to work on a committee and play with the team. And if they're going to fund this and they're going to cut off our funding because we make them look stupid by showing a mechanism of action." And the guy said, wait, I'm a clinician. I just want to know, do you think this is plausible? Do you think this is cost effective? Do you think this is procedurally doable? Do you think that this is useful for the patient? And the other two doctors said, yes, it is, but we are not going to put our name on it and we are not going to let you sign this. And besides, much progress, so she's getting transferred. Sure enough, she was transferred. And that memo, that letter never got written. And today, this is December 6th, he's saying to me that he's so sad that everything he's putting together doesn't get an audience. And ethically, he feels guilty. I happen to be writing a weekly newspaper column that all of you guys know about. Some of them have been extremely well received. by scientists, but does it ever go anywhere? Dio Pujari has seen them. Vinod Kumar has seen them. They've made their way to the PMO. I have been speaking and speaking about mechanisms of action, cost benefit, the flame of fire in the gut affecting the phlegm in the tongue. No one wants to listen. Why? Because it's not coming from the people who are expected to write the answers and present them. I don't know how else to say it. There are so many of us clamoring with solutions.
Bhaswati, we know exactly what you mean. What you're offering is what is known already. The challenge for us is to break through the system.
Yes.
And we know these problems, and we know them from decades, that these are problems. And everybody in policymaking knows there is a problem. Government policymaking is always biased. We know that. The challenge is to find your way through and to make an impact. And that might look, it might seem dirty and unethical, but if that is the way, that's how it's got to be.
It's the way.
And the lessons, we are fortunate to have the 700 verses of the Bhagavad Gita here to guide you. We're not shying away from those responsibilities. And if we don't take on the 700 verses of the Bhagavad Gita and the lessons there and do something about it, we are not getting it right. And we are the ones to be blamed. So we know all these things.
Yes.
I can give you the exact amount of money and when it was transferred from Pfizer to the Serum Institute. And we know exactly the quantum of money that was transferred from the Bill Gates Foundation to Hindustan Biotech. We know all these things. We know how monies are moving around the world. We know all this. The challenge for us is to cut through all of that, which are barriers, of course, they are barriers to where we want to go. But the skill is to work through those barriers like they don't exist and to bring about global policy change. And this is, as I repeat what I said earlier, this is the very essence of coming together here so that we at least identify people who have that passion and who have clarity in their minds and their hearts to bring about change.
Madan,